Good afternoon, everyone. And today, on behalf of Department of Rheumatology, I welcome you all to this clinical combined round. And today, keeping with the trend of AIIMS CCRs, we are also presenting something very interesting, gem out of the mine. So, for that, I'll invite Dr. Danveer Bhadu to start the presentation.
Thank you, madam. Good afternoon, everyone. Today we are going to discuss one of the interesting story of the interesting case, which is where we have involvement of multiple departments. You know that this is a title where we have given multidisciplinary approach. So multiple departments were involved, and the story is very interesting. We are going to share the interesting story with you, and probably you will enjoy that. So I will start that his presentation with Dr. Parinita. Dr. Srail, I will discuss the literature. Dr. Yamini from the nuclear medicine. Dr. Abhishek from the neurology. Dr. Reva from endocrine surgery, and Dr. Superja from radiodiagnosis. So all of them will discuss their part. And now I would like to invite Dr. Parinita to start the presentation.
Good afternoon, everyone. I'll be presenting a case of a 55-year-old male, resident of Noida, a field worker by occupation, accompanied by his wife, on 22nd March 2024, with a diagnosed case of rheumatoid arthritis from outside based on the history of symmetric polyarthritis. He was on treatment of methotrexate, steroids, and febuxostat and was referred to AIIMS Neurology for change in voice and dysphagia. From neurology, this patient was referred to rheumatology OPD for the evaluation of polyarthritis and possible atlantoaxial dislocation. His chief complaints were polyarthritis involving the small and the large joints associated with deformities since last 5 years, right jaw pain since 1 year, change in the voice with nasal intonation since 10 months, cough while swallowing food since 3 months, and low back pain since 2 to 3 months. Negative history, he never had any history of red eye, photophobia, weakness, paresthesia in the limbs, neck pain, gait disturbances, rhinorrhea, epistaxis, bowel bladder involvement, chest pain, difficulty in breathing, fever, weight loss, loss of appetite, abdominal pain, vomiting, constipation. Past history, he had a history of RTA 26 years back and he had right forearm fracture for which he was operated. History of loss of vision in the left eye 17 years back, which he says probably he had an infection for which he received some intraocular injection. We don't have any records for this. No, he is a known case of hypertension since last 5 years and is on telmisartan. And he had some left elbow soft tissue surgery done 2 years back, for which again the records are not available. Personal history, he had a history of alcohol consumption for approximately 72 grams per week since last 15 years, and he stopped since 3 years in view of increased joint pains, and he is also a tobacco chewer. On examination, his vitals were stable. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, pedal edema. In this, we can see that patient has swell neck deformity in the second, third, bilaterally, and patient also had Z deformity in the thumb. And in the second image, we can see that the patient has this correctable deformity. X-ray neck was suggestive, it was not suggestive of atlantoaxial dislocation. And this is a video of his speech. Outside reports, it was all within normal limits. RF, NTCCP, ANA, ENA was all negative. CE MRI brain done outside, suggestive of diffuse cerebral atrophy with non-specific ischemic changes in the supratentorial compartment. So here we were actually in a doubt. Does this patient really has RA or is it something else? So we ordered some tests, and in the next OPD, patient had RF, NTCCP, ANA, AMCA, it was all negative. ESR was 30, CRP was 2.9, and uric acid was 7.3. We also ordered X-ray hands and MRI brain, which patient got from outside, was discussed in the radiology department, which Dr. Supraja will be discussing now. So I welcome Dr. Supraja.
So we have the cervical spine radiograph, lateral view, and in this there is normal alignment. There's maintained cervical lordosis. Just mild degenerative changes are there in the form of osteophytes. There's mild periodontal calcification, however, there's no obvious atlantoaxial subluxation. We also have bilateral PA radiographs of the hands, and in this the most striking abnormality is that of the proximal interphalangeal joints. Here we can see juxta-articular punched out erosions of multiple PAP joints bilaterally. And these are juxta-articular. They are not involving the joint space. They are not marginal as in rheumatoid arthritis. And a few of them are also seen involving around the MCP joints, like in the right second and the left fifth finger. And there is periarticular osteopenia, particularly around the MCP joint. And bilateral ulnar styloid processes are not clearly seen. Either it's because of inflammatory arthritis related involvement, or the patient has a history of trauma, so it could be previous trauma related also. And one thing to notice that the carpal joints are spared in this. And in this, we can see that there are bilateral old malunited fractures of radius with plate and screw fixation in the right side. And in the lateral view radiograph, most of the fingers are showing swan neck deformity, which is hyperextension at the PAP joint and flexion at the distal interphalangeal joint. So although there are some features favoring RA like the swan neck deformity or the periarticular osteopenia, the most striking abnormality is that of the punched out erosions, which are not involving the joint space, which is typical of gout. We also have MRI brain images, and in this there are a few small T2 flare hyperintensities in bilateral frontal parietal white matter, which are possibly related to small vessel ischemic changes. This is a heavily T2 weighted sequence which is done for the cranial nerves because the patient has dysarthria. The cranial nerves were also normal. Small old pontine infarct is also seen on the right side. Over to Dr. Kapil.
So the search begins again. On examination, we found that patient had redness and nodule over the pinna, and there was a swelling in the below the bilateral elbow joint. So here we had a differential diagnosis of rheumatoid arthritis, gout, and relapsing polychondritis. To support the diagnosis of rheumatoid arthritis, the patient had inflammatory polyarthritis, change in the voice which can be explained by involvement of cricoarytenoid joint, and jaw pain which can be explained by temporal joint involvement. But patient had RF anti-CCP negative and reducible deformity, which causes a less chances of rheumatoid arthritis. Then for gout, patient had inflammatory polyarthritis, change in the voice, again because of the crystal deposition it can happen. Then jaw pain and soft tissue calcification and soft tissue mass is seen in the gout. And patient also had hyperuricemia. So we did the ultrasound, and in ultrasound we found that it was a completely destructed joint. And in this, this is the phalanx, this is the metatarsal head, which is completely destroyed and is full of calcification, and there is acoustic shadow present. So we couldn't make out a double contour sign which is specific for gout. So for the third differential, we had inflammatory polyarthritis, change in the voice, and red ear. So patient had auricular chondritis, possible tracheal chondritis, and correctable joint deformity. So we thought maybe it is RP with possible gout. So we ordered FDG PET for the patient, which will be discussed by Dr. Young.
The FDG PET-CT images of the patient shows polycystic lesion in relation to right lobe of thyroid, which is non-avid, along with multiple metabolically active soft tissue thickening with calcification in relation to lateral aspect of bilateral claviculi, sternoclavicular joint, posterior aspect of bilateral elbow joints, and first metatarsal, with diffusely increased FDG uptake in tarsal metatarsal joints and intertarsal joints. There is soft tissue thickening with metabolically increased uptake with FDG uptake in bilateral periarticular regions in knee joints, with
metabolically active lytic destruction in relation to the spinous process and interspinous region in L3 to L5 vertebrae. The overall scan findings were suspicious for right parathyroid adenoma with gouty arthritis and bursitis and synovitis involving the axial and appendicular skeleton.
So to our surprise, the relapsing polychondritis was out, and we have a new finding, parathyroid adenoma. For the involvement of cricoarytenoid, we got the ENT consult done, and laryngoscopy was done, which was suggestive of bulky arytenoids. Meanwhile, we aspirated the soft tissue swelling which was present below the right elbow, and it was suggestive of negatively birefringent monosodium urate crystals. And since patient had parathyroid adenoma, so serum calcium was done, which was 13, and phosphate was 1.7. So we managed it with IV fluids and diuretics. So till now, we had a diagnosis of chronic polyarticular tophaceous gout with primary hyperparathyroid, but dysarthria we still couldn't explain. So we got the DECT neck done and ultrasound parathyroid for further evaluation. So over to you.
So DECT was actually done for both the feet and the neck. And this is a baseline CT images of the foot, which show diffuse osteopenia and the typical punched out tract bite erosions of gout, which we can see in the fibula in almost all the tarsals with overhanging margins. And besides that, there is also joint space narrowing and irregularities in the joint, which can happen with chronic gout or with secondary osteoarthritis related changes. In the volume rendered images, we can also see deposition over the bilateral first MTP joint, which is the most common site of gout involvement, and along the lateral aspect of the fibula. The corresponding CT images also show high density deposition over the bilateral first MTP joint with punched out erosions with overhanging margins of the adjacent bone. These are the processed images from DECT, and they show gout crystal deposition over first MTP joint as well as over other MTP joints and over most of the tarsal and intertarsal joints, as well as the first costochondral junction. Ultrasound was done over the stophi, and they showed hypoechoic heterogeneous lesions, and the underlying joint showed irregularities of the articular surfaces. And just like it was mentioned before, incidentally, the NCCT images also picked up a well-defined hypodense lesion, which was adjacent to the inferior pole of the right lobe of the thyroid. It was abutting the thyroid, the trachea, and the esophagus. Ultrasound of this lesion showed a solid cystic appearing lesion with central cystic area, and a well-defined echogenic capsule was separating it from the adjacent thyroid. So this is the thyroid and this was the lesion. And it also showed the typical peripheral vascularity which we see in a parathyroid adenoma. So this was a cystic parathyroid adenoma, although which is rare, can still occur. I request Dr. Yamini to continue with the system EPC.
These are the early images of the system EB of this patient. The planar images, 15-minute planar images shows diffusely increased tracer uptake in both of the thyroid gland with the focal accumulation in relation to the right lobe of thyroid, which shows persistent in the delayed images. However, there is partial washout from the lesion. The SPECT CT images taken at 50 minutes shows maybe having solid cystic lesion in relation to the right lobe of thyroid gland. The overall scan findings are consistent with right parathyroid adenoma.
So after this, dysarthria, we didn't have any cause, so we repeated the ENT, we went to the ENT again, and FOL was done again, which showed there's no connection between the larynx and the dysarthria. So why we have dysarthria? We did the DCT, we couldn't find, then PET CT, there was no chondritis. So we went back to neurology, and here the neurology findings will be explained by Dr. Abhishek.
We reviewed his history. Since October 23, the patient had a weakness in his right hand, and it was a distal predominant weakness, and he had a difficulty gripping objects and buttoning his shirt. And by Jan 24, he developed a coughing whilst he was eating food. That was probably because of some difficulty swallowing, and his speech grew so slurred that his relatives couldn't understand what he was speaking. Okay, on occasion. There was no slippage of footwear. There was no difficulty getting up from a seated position. There were no sensory complaints. There were no bowel and bladder complaints, and the patient had no difficulty reaching out to overhead objects. On examination, here we see a wasted first dorsal interosseous. We see wasted thenar and hypothenar eminences. We see a wasting of bilateral deltoid, biceps, and the triceps also was wasted. We see a wasting of the brachioradialis and the flexor carpi ulnaris as well. We see a very thin atrophic tongue. We tried to look for fasciculations. There are very fine fasciculations which we could not pick on the camera. And this is a video of his slow tongue movements, and it explains his spastic speech. The video was shown by Dr. Parinita earlier. His power was relatively well preserved. In the right upper limb, it was 4+. In the left upper limb, it was 4-. Grip was reduced, but probably that was because of his joint deformity. Power in the lower limbs also was preserved. He had brisk reflexes, and he had an ill-sustained ankle clonus. Bilateral planters were downgoing. This is a snapshot of his needle EMG, which was done in the biceps, which shows us discrete potentials, which is suggestive of a neurogenic pattern of involvement. He had neurogenic pattern in both cervical as well as lumbosacral segments. So this satisfies the Gold Coast criteria for ALS with progressive motor impairment, which is documented by history, and he's having upper and lower motor neuron dysfunction in one body region. So that is in the cervical region. He's having a wasting, which I have shown you is the first dorsal interosseous, biceps, triceps. They're all wasted with brisk reflexes. Although we haven't reliably excluded the other diseases which we want to. So from a neurological perspective, this looks like an ALS pending other DDs.
So finally, we had a diagnosis of gout with primary hyperparathyroid with motor neuron disease and hypertension. So patient was admitted and patient underwent parathyroidectomy, which will be explained by Dr. Renu.
So with concordant localization of our adenoma to right inferior parathyroid, we have performed a focused parathyroidectomy for this patient under ultrasound guided bilateral cervical plexus block with conscious sedation. Patient was in supine position. The incision was made. If we can just go through, then the right thyroid lobe was dissected and retracted immediately, and just behind that lobe, you could see the right thyroid adenoma. So the adenoma was a very dense cystic swelling, and it was densely adherent to the surrounding structure, infiltrating into the vertebral fascia as well. After meticulous dissection, this parathyroid adenoma was dissected. This was the post-surgery picture. This was the parathyroid adenoma measuring 1.37 grams. And after the surgery, the IPTH levels had dropped to 10.8 and the serum calcium levels had dropped to 10.8 in post-operative day 0. And on post-op day 2, the serum calcium had further dropped to 9.7. So we had successfully removed the parathyroid adenoma that was present.
So to summarize, on 22nd March, patient came to us with the diagnosis of rheumatoid arthritis with probable atlantoaxial dislocation. On 2nd April, we gave the differential diagnosis of rheumatoid arthritis, gout, relapsing polychondritis. After doing the PET, we had the diagnosis of gout with primary hyperparathyroid, but we didn't have any answer for dysarthria, which we got on 15th of April after the neurology consult. We had gout, patient has gout, hyperparathyroid, and motor neuron disease. Patient was admitted and underwent right parathyroidectomy on 20th April. And from the rheumatology department, patient was further managed with colchicine and allopurinol. So for review of literature, I'll call Dr. Shaina.
Before we go into the review of literature, we will go a little bit of detail into the case at hand, that is gout. So gout is the most common inflammatory arthritis in the US. The prevalence of gout in India is almost 0.12 to 0.19% in the community. The pathogenesis, to understand the pathogenesis of gout, we will first look into the urate excretion pathways in our body. Urate is 100% filtered at the glomerulus and it is 90 to 98% reabsorbed at the PCT. There are several urate transporters in the PCT, both in the apical membrane, such as the URAT1, OAT4 and 10, and then in the basolateral membrane, OAT1 and 3, and also the ABCG2 and the NPTs, which are involved in the secretion and the reabsorption of the urate. Finally, 90 to 98% of it is reabsorbed and a total of 10% of the filtered load is excreted from the body. The pathogenesis of the gout begins when, due to any reasons that could also be a dysfunction of these transporters, that leads to a urate accumulation and formation of the monosodium urate crystals, which further via the several pathways in our body, which are involving TLRs and inflammasomes such as NLRP3, results in the activation of interleukin such as interleukin 1 beta and results in the manifestation of gout. The clinical manifestations of gout normally is as an acute arthritis, which is usually a monoarthritis involving the first MTP joint. It can also come as varied manifestations such as chronic arthritis, extra-articular tophi, tenosynovitis, urate nephropathy, and acute uric acid lithiasis. Our case is a case of polyarticular gout. So polyarticular gout is not a very common manifestation. It is the initial manifestation in less than 20% of the patients and it poses a diagnostic dilemma. Patients who are more likely to have a polyarticular gout are the patients who are having multiple recurrences, untreated gout, absent symptom-free intervals, palpable tophaceous deposits, multiple medical comorbidities, transplant recipients, and patients with multimorbidities such as obesity, hypertension, and when hyperuricemia is secondary to a lymphoproliferative disorder. Acute polyarticular gout has been known since a very long time, and this is a review in which it was shown that similar to our case, in around 41 male patients, the polyarticular gout was misdiagnosed as rheumatoid arthritis, septic arthritis, degenerative arthritis, and even hemiparesis. But notable is that in all these patients, there was a medical history suggestive of the acute gouty attacks. The atypical manifestations of gout are so varied in that it can involve any part of our body. A few of the case reports that I have put here are atypical localizations of the tophi that can involve head and neck, the viscera, dermatological gout, or axial gout. Gout can even involve the colon, which can mimic carcinoma colon. It can involve fascia, it can involve tendons, it can even present as supraorbital masses, as patellar masses. Even in the spinal cord, there have been reports where tophi have occurred. So the message is that gout can involve any part of the body. Coming to primary hyperparathyroidism, most commonly primary hyperparathyroidism is an asymptomatic disease. It is detected as an asymptomatic hypercalcemia in almost 80% of the patients. The symptomatic primary hyperparathyroidism is common in the developing world such as India. Normocalcemic hyperparathyroidism and parathyroid crisis are rare manifestations. Symptomatic hyperparathyroidism is associated with hyperuricemia and gout, and it is a known association. But the rheumatic manifestations of primary hyperparathyroidism is usually as CPPD, commonly known as pseudogout. That is the most common etiology. But we know that hyperuricemia is a long recognized entity, but the frequency of gout is not known, and the mechanism of hyperuricemia is as yet poorly understood. But we will see what are the evidences that we have to connect the PTH to the uric acid. So we have evidences of increased uric acid in patients treated with PTH. There are several case reports of hyperparathyroidism eventually developing gout and then reversed with surgery. And there are some theories proposed such as the downregulation of the transporters that I had mentioned earlier in the pathogenesis. One of these is the urate transporter such as ABCG2. This was a basic science animal research study which demonstrated an ABCG2 downregulation by PTH and an NHE3 regulation via PTH. And a similar case, they have found out that primary hyperparathyroidism eventually was diagnosed with oligoarticular gout, but Difference is that in this case, there was no history of long-standing arthritis, which makes it different from the current case. Coming to the unsolved mystery, that is the motor neuron disease. So there are case reports of motor neuron disease mimics, which were diagnosed contemporaneously with PHPT. And there are case reports of MND, which were having aberrant calcium and phosphate metabolism, but a definite causal link has not yet been established. A similar report is a 36-year-old male who was having wasting and atrophy of the muscles with incidentally detected PHP. But the important point to note was that in this case, there were no UMN features, there were no fasciculations. The authors have concluded that it was an MND mimic and the symptoms reversed after the surgery. Similarly, in this case report, there were no UMN signs and fasciculations and the symptoms reversed with surgery. A case series of 5 patients from Spain was reported in which there were 5 patients with definite primary hyperparathyroidism and also definite ALS. But these patients had progressive disease and eventually succumbed to their MND. So MND with primary hyperparathyroidism still remains an unsolved mystery. We do not know whether there is a real association between them or whether it is a coincidence. There is a debatable association in case reports of PHP with MND. There is an inconsistent recovery post-surgery and a possible cause is not yet explained. Also, hyperuricemia may be protective for some neurological disease and there is yet no biological explanation for a gout association with motor neuron disease. So the take-home points from today's case is that polyarticular gout is an uncommon presentation of a common disease and any unexplained feature in a patient needs to be followed to the end. Because in our patient we had followed the cause of dysarthria to the end, we were supposed to diagnose it as a case of MND. And gout is one of the causes of arthritis apart from CPPD in a patient with primary hyperparathyroidism that needs to be kept in mind. And primary hyperparathyroidism may have an association with MND. So I would like to acknowledge all the departments who have helped us in solving this case mystery. And now I would like to invite Dr. Dhanveer sir to say a few words.
So, this case was really we were to correlate the pathway this actually have the theory and try to find out in the form of whether it is mobile this so in search of this we have found this immunity, which is another diagnosis which is in the initial period where we have something now primary parallel and immunity. All these three are independent and not linked to each other. In this case, particularly because parallel was integrated, this already was successfully found to have because of this happening. So this specific managed team medicine was considered and every department was involved. In the last 1 month, we have a lot of exercises to this. Now I would like to have a little bit of system house.
We have lots of previous calcium hospitals, and we start with calcium
Calcium and phosphorus are available in the field, and we have ordered PET scan, which was just to so we have then after gene timing. So coming from this side,
for every year,
so we have 2 days only, and there is no improvement in the voice right now. Only improvement is in PTS level and it's just level. There was a difficulty in doing surgery also. What is it? So, because of the reluctance of giving general anesthesia owing to the presence of MND, so Dr. Parin and her team gave cervical plexus block. And we could not extend the neck also because of the possibility of atlantooccipital dislocation, although it was ruled out earlier. So it was a supine position with cervical plexus block, but we somehow managed. And going to your question, looking at the gland, it was quite tense and there was cystic degeneration. And once we cut that, we found necrotic tissue and only small area of fleshy parathyroid, normal parathyroid was there. That suggests that it must have been a long standing gland. So that's one. And of course, we have removed that. We hope recovery, but again, causal relationship cannot be established at this point. Thank you.
This case was very challenging from anesthesia point of view as the patient didn't have any gag reflex. So if once the patient would have been intubated, then it would have been extremely difficult to wean him off from the mechanical ventilation. And with Piyush, we planned for post-op tracheostomy in case if we required to give GA and intubate the patient. So we decided to give superficial cervical plexus and intermediate cervical plexus block ultrasound guided with dexmedetomidine sedation in neutral position as the patient was having cervical myelopathy. So we could not even, we were trying to prevent the extension of the neck. And yes, it helped us.
Thank you. I think we are running. Yeah. Maybe. Yeah, maybe. Yeah, we will update you. So, in the interest of time, I think we are running short of time and we will hand over that to gynecology department.